Before dawn, the river is quiet. Mist hangs low over the water, softening the outline of the city. Rowboats cut through the fog, carrying figures who do not speak. Some are sick, some are exhausted, some are already dying. They are taken not to a home, not to a church, but to a building that promises care. Inside, doors close gently, ledgers open, names are written down, often misspelled, sometimes not written at all. What happens next is not announced, and for decades, almost no one asks. In the middle of the 19th century, the United States is changing faster than it can understand itself. Cities swell with newcomers. Ships arrive daily heavy with people from Ireland, Germany, Italy, Eastern Europe. Many arrive hungry. Many arrive ill. Most arrive with no money and no political power. Public hospitals expand to meet the need. They are not designed to be welcoming. They are designed to be efficient. In New York City, on the eastern edge of Manhattan, Bellevue Hospital grows into one of the largest medical institutions in the nation. Across the river, on Blackwell's Island, a network of hospitals, asylums, and infirmaries rises to contain the poor, the sick, the unwanted. These places are described at the time as humanitarian achievements. They offer beds, they offer food, they offer treatment to those who would otherwise die in the streets. They also offer something else, a steady supply of human bodies. In the 19th century, American medicine is still searching for legitimacy. Germ theory is contested. Anesthesia is new and imperfect. Many treatments are experimental by necessity, not design. There are few regulations. There is no formal concept of informed consent. Medical education depends on observation, dissection, and practice. Hospitals attached to teaching institutions become laboratories of learning. The poor are admitted, the wealthy are treated at home. This distinction is not hidden, it is openly acknowledged. Charity patients are considered different. They are described in medical journals as material, as cases, as opportunities, and most of them are immigrants. The system functions smoothly. A patient arrives by wagon or boat. Their clothing is taken. Their belongings are inventoried, if they exist at all. They are assigned a ward based on sex, diagnosis, and perceived cleanliness. Doctors make rounds in groups, students follow behind, notebooks open, examinations are conducted publicly, bodies are exposed. Questions are asked, often in English, regardless of whether the patient understands the language. Treatments are administered according to prevailing theory. Bleeding, mercury compounds, experimental surgeries, new drugs with unknown effects. If the patient survives, the case is noted as a success. If the patient dies, the body does not immediately leave the institution. Autopsies are routine. They are considered essential to progress. In some hospitals, patients are effectively enrolled in experimentation upon admission. This is not presented as a choice. It is understood as part of the cost of care. No consent forms are signed. No translators are present. In annual reports, administrators describe this as efficiency. In private correspondence, some physicians describe it as opportunity. Among the patients are women whose names appear only briefly in records, if at all. Immigrant women, many of them Irish, admitted for childbirth complications, infections, or chronic pain. Gynecology in the 19th century is an emerging field. Surgical techniques are being refined. Surgeons need practice. Public hospitals provide access. Procedures are attempted repeatedly, sometimes on the same patient, sometimes without anesthesia. Failures are recorded clinically. Pain is rarely mentioned. Children are present as well. Orphans, the children of the sick, the children of the dead. They are treated for infectious diseases. They are observed closely. Some are given experimental treatments to test dosages and effects. When they die, their deaths are attributed to the severity of illness. The possibility that the treatment contributed is rarely considered. Nurses notice patterns. Some complain quietly. Others accept it as unavoidable. The institution does not pause. Not everyone inside the hospital is cruel. Many physicians believe sincerely in progress. They are trained to think in terms of populations, not individuals. One life, they reason, may be sacrificed to save many more in the future. This logic is not whispered, it is taught. Medical journals of the era publish case studies drawn almost entirely from public hospital patients. Immigrants become anonymous contributors to American medical advancement. Their names are replaced by initials. Their origins are reduced to categories. Irish female, age approximately 30. German laborer, no family present. Their suffering becomes data. The turning point does not arrive with a scream, it arrives in accumulation. In mortality rates that are higher in teaching wards than in private care, in repeated experiments that fail but continue anyway, in internal reports noting useful observations following deaths, in bodies buried in institutional graves, sometimes without markers, sometimes without records. Occasionally, an outsider notices. A journalist writes a brief article questioning conditions on Blackwell's Island. A reformer requests access and is shown only selected wards. A city council member raises concerns, then moves on to another issue. The hospital continues to function because it is legal, because it is respected, because it serves a population that cannot easily protest. What is hidden is not always actively concealed. Much of it disappears through neglect. Records are lost. Ledgers deteriorate. Names are misspelled beyond recognition. Patients discharged alive are not followed. Patients who die are counted, but not mourned. Families often never know what happened. Many immigrants arrive alone. Others are separated by disease, language, and bureaucracy. There are no lawsuits. There is no mechanism for accountability. Medical schools continue to send students. The city continues to fund the institutions. The work continues. By the late 19th and early 20th centuries, medicine begins to change. Standards slowly emerge, ethics are debated. Consent becomes a topic of discussion, though not yet a requirement. Some practices are quietly abandoned. Hospitals modernize, buildings are renovated, wards are renamed. Bellevue becomes a symbol of excellence. Blackwell's Island is rebranded, then eventually transformed. No formal reckoning occurs, no memorial lists the names of those who were experimented on. No official apology is issued. The knowledge gained is absorbed into textbooks. The patients vanish from the story. Today, the hospitals still stand, in name or in legacy. Medical advances achieved in the 19th century are taught as milestones. Rarely is it mentioned where and on whom that knowledge was built. The silence is not accidental, it is structural. The system rewarded results, not reflection. It still does. And the question remains, unanswered in the records and unresolved in the present, who pays the price for progress when the people involved are easy to forget? The river still moves past the city, the buildings have changed. The logic has not entirely disappeared, and history, when left unexamined, does not stay in the past.